Good evening, everyone. Today's my topic for the presentation is basic management of retinal diseases, which we will be understanding under the headings of first, the spectrum of retinal diseases, manageable versus non-manageable retinal diseases, principle of management, common management across most retinal diseases, such as systemic optimization, anti-VEGF therapy, laser therapy, steroid therapy, vitrectomy, oral medication, supportive or adjunctive care, low vision aids. First of all, a spectrum of diseases. First, age-related macular degeneration and other choroidal neovascularization, such as ocular histoplasmosis syndrome, angioid streak, pathological myopia, idiopathic CNVM. Second, diabetic retinopathy, non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, diabetic macular edema. Third, retinal vascular diseases and associated with cardiovascular diseases such as hypertensive retinopathy, retinal venous occlusion, ocular ischemic syndrome, and retinopathy. Arterial occlusive diseases, arterial microaneurysm. Fourth, other retinal vascular diseases, sickle cell disease and retinopathy, vasculitis, cystoid macular edema, Coats disease, macular telangiectasia, phacomatosis, radiation retinopathy, Valsalva retinopathy, posture retinopathy, Turson syndrome. Fifth, retinopathy of prematurity. Sixth, choroidal disease, CSCR, choroidal perfusion abnormality. Seventh, inflammatory, non-infectious white dot syndrome, chorioretinal autoimmune conditions, sympathetic ophthalmia, uveitis masquerade, infectious CMV retinitis, non-CMV necrotizing herpetic retinitis, bacterial endophthalmitis, fungal endophthalmitis, ocular tuberculosis, ocular bartonellosis, toxoplasma chorioretinitis. Eighth, hereditary color vision abnormalities, night vision abnormalities, retinal and choroidal dystrophies. Ninth, degeneration associated with systemic disease, with systemic involvement, infantile onset to early childhood onset syndromes, Bardet Biedl syndrome, Usher syndrome, neuromuscular disorders, metabolic diseases, albinism, CNS associated metabolic diseases, amino acid disorders, mitochondrial disorders. Ninth, surgical or mechanical, rhegmatogenous retinal detachment, tractional retinal detachment, exudative retinal detachment. Manageable versus non-manageable. Manageable diseases are diabetic retinopathy or diabetic macular edema, retinal vein occlusion, exudative, age-related macular degeneration, CSCR, macular hole, epiretinal membrane, retinal detachment, rhegmatogenous or tractional, uveitic retinopathies, early stages of retinopathy or prematurity, non-manageable or those with limited outcomes will be retinitis pigmentosa, geographic atrophy, end-stage macular scarring, advanced optic atrophy post-occlusion, chronic non-functional retinal detachment. The principles of management will be to identify the pathology like ischemia, leakage, traction, or inflammation, then to preserve the vision with early treatment before macula is compromised, then to prevent the progression with PRP laser or anti-VEGF injections, then optimize systemic factors like blood pressure, glucose, and lipids, then to restore the structures with surgery like pars plana vitrectomy and buccal surgery. Common management across most retinal diseases will be first will be systemic optimization, then second anti-VEGF therapy, third laser therapy, fourth will be steroid therapy, fifth will be pars plana vitrectomy, sixth will be supportive or adjunctive care. First, systemic optimization. In systemic optimization, we need to optimize the HbA1c with glycemic control, like HbA1c should be in the range of 6 to 7%. Then the control of the BB, which should be less than 130 by 80 mmHg. Then lipid should be, which is LDL, it should be less than 70 mg per dl. Then we need to correct the anemia, which requires hemoglobin to be 12 to 16 gram per dl. Then we need to get the cessation of the smoking. All these are required to be under control, because what chronic hyperglycemia do is, chronic hyperglycemia leads to sorbital buildup through the polyol pathway, which leads to the pericyte apoptosis, leading to fragile capillaries to be formed, and then capillary occlusion or dropout, which leads to retinal ischemia, which leads to increase in VEGF, which ultimately leads to neovascularization and macular edema. Controlling the HbA1c reduces the microaneurysm and reduces the leakage, and also reduces the VEGF. And hypertension leads to the arteriolar vasoconstriction with structural narrowing, which leads to the injury of endothelial cell, which leads to vascular leakage and ultimately retinal and choroidal ischemia. Controlling BP leads to reduction in the arteriolar damage and BRB breakdown. Controlling lipid is necessary, because dyslipidemia increases the circulatory lipoproteins, which increases the damage of retinal vessels, which leaks the proteins, lipoproteins. They deposit as a hard exudates, which leads to the persistent leakage and further causes chronic macular edema and triggers the inflammation. Controlling lipid causes reduction in hard exudates, reduction in chronic inflammation. Controlling anemia is necessary, because low hemoglobin reduces oxygen delivery, which leads to the retinal hypoxia and stabilizes the HIF-1 alpha factor, which ultimately increases the VEGF overproduction, which leads to the pathological neovascularization on retina, disc, or iris. HIF-1 alpha will be hypoxia induced factor 1 alpha. Controlling anemia leads to increase in oxygen, which reduces the hypoxia and ultimately reduces the VEGF. Smoking cessation is necessary, because smoking increases the reactive oxygen species and reduces the choroidal perfusion, which leads to the RP or Brooks membrane damage, which leads to the VEGF increase, and then structural break happen, which leads to the faster development and progression of choroidal neovascularization membrane. Smoking cessation leads to reduce in oxidative stress, and it also reduces the choroidal damage. Then comes anti-VEGF therapy. The principle for anti-VEGF therapy is, as the VEGF, which is a vascular endothelial growth factor, it promotes the angiogenesis. And the sequelae of angiogenesis is, in the angiogenesis, there will be vasodilatation of existing vessels. Along with, there will be increased permeability of the vessels, which leads to the plasma proteins and growth factors to be leaking, and then extracellular membrane degradation occurs, which leads to the endothelial cell migration and also proliferation. Endothelial cells then align and join to form the lumen, which stabilize the new capillaries and also form the stable vascular network. Anti-VEGF drugs bind with the VEGF and also prevent VEGF to attach to the endothelial cells, and reduces the neovascularization and further reduces the vascular permeability, then reduces the macular edema which ultimately cause the improved vision. There are several anti-VEGF available, like first bevacizumab, ranibizumab, aflibercept, brolucizumab, and faricimab is the newest one. Bevacizumab is a full-length humanized monoclonal antibody with the molecular weight of 149 kilodalton. It mainly targets the VEGF-A, and it is the only drug which is not approved by FDA. Indication for bevacizumab is age-related macular degeneration, diabetic macular edema, retinal vein occlusion, and CNVM. Intravitreal dose is 1.25 mg per 0.05 ml, and intravitreal half-life will be around 10 days. It is widely available due to the low cost, and it has a good systemic absorption. Then comes the lucentine, which is ranibizumab. It is a Fab fragment with the molecular weight of 48 kilodalton. It targets the VEGF-A. It is approved by the FDA, and indication will be age-related macular degeneration, diabetic macular edema, retinal vein occlusion. Intravitreal dosing is 0.5 mg per 0.05 ml, and half-life will be around 9 days, and its advantage is it is high retinal penetrating in nature, and it is costly, and we need frequent injection for ranibizumab therapy. Then comes the aflibercept, which is Eylea. It is a fusion or VEGF trap with the molecular weight of 115 kilodalton, and it targets VEGF-A, VEGF-B, and plasma-induced growth factor. It is approved by FDA, and indication is age-related macular degeneration, diabetic macular edema, retinal vein occlusion, myopic CNVM, and intravitreal dosing is 2 mg per 0.05 ml. Half-life will be 7 to 9 days. Advantage, it has a high binding affinity, and it works with longer duration. It is costly, and it has a systemic exposure as well for aflibercept. Then comes the brolucizumab. It is a single chain antibody fragment which is the smallest in molecular weight. It has the molecular weight of 26 kilodalton. It mainly targets VEGF-A and approved by FDA. Indication will be age-related macular degeneration, and intravitreal dosing 6 mg per 0.05 ml. Half-life will be 5 to 6 days, and it has longer dosing interval potential around every 12 weeks. We can give the interval of 12 weeks for injection of brolucizumab. It also has the risk of intraocular inflammation. Then comes the faricimab. It is a bispecific antibody. It has a molecular weight of 150 kilodalton. It mainly targets VEGF-A and angiopoietin 2. It is approved by FDA, and indication will be age-related macular degeneration, diabetic macular edema, and intravitreal dosing will be 6 mg per 0.05 ml, and half-life will be around 7 days. Advantages, it has dual mechanism and longer duration. It is a newer drug, and also it is costly. Then overall indications will be center involvement, diabetic macular edema, proliferative diabetic retinopathy or severe non-proliferative diabetic retinopathy, then CRVO associated macular edema, BRVO associated macular edema, wet AMD or exudative AMD, CNVM, myopic idiopathic inflammatory, type 1 ROP, refractory post-op CMV, neovascularization of iris or angle. It it is also used as a adjunct in neovascular glaucoma. Chronic CSCR with CNVM. Dosing will be, it is used with loading dose, and which is followed by maintenance dose. Loading dose is used as a 3 monthly dose. Three doses of intravitreal are initially given with the interval of 1 month for 3 months. It is a loading dose or loading phase. Then maintenance dosing is done with three types of strategies like fixed dose method or PRN, which is Prorinata, then treat and extend. In fixed dose, there are injection given monthly or every 8 weeks depending on the drug. Then in PRN or Prorinata, we need to inject the intravitreal injection when activity of the disease appears. Then comes the treat and extend. We need to extend it the interval by 2 weeks up to the 12 to 16 weeks. Then monitoring can be done with the visual acuity or best corrected visual acuity, and IOP can be measured after every injection. Fundus examination can be done to look for the hemorrhages or CNVM activity. OCT can be done for intraretinal fluid, subretinal fluid, or central macular thickness. These can also be used to see the response after each injection cycle. Contraindication will be active intraocular infection, periocular infection, pregnancy, recent stroke or MI, hypersensitivity to the drug. Complication will be endophthalmitis, IOP spike, cataract from needle touch, retinal tear or detachment, inflammation, systemic thromboembolic event. Then comes the steroid therapy, which can be intravitreal triamcinolone acetate or Ozurdex or oral. The principle will be to reduce the inflammatory edema, to have the longer duration of action, and it is used when VEGF blockade is insufficient. First, intravitreal triamcinolone acetonide, which has the dosing of 4 mg and it lasts around 3 months. It is mainly used for retinal vascular occlusion. Also, the indications are diabetic macular edema, especially and in anti-VEGF non-responders, then retinal vein occlusion related macular edema, then uveitic macular edema, pseudophakic cystoid macular edema, which are refractory, then serpiginous retinochoroiditis with severe inflammation. Triamcinolone acetinoid is available as Oracort. Then comes oral steroid, which are used for uveitis with the dosing of 1 mg per kg, then followed by tapering. Indication will be severe posterior uveitis, panuveitis, retinal vasculitis, acute Vogt Koinagi Harda, symptomatic ophthalmia, Behçet disease, optic neuritis with IVMP protocol and intravitreal methylprednisolone protocol, bilateral retinal diseases. It is available as a brand name of Visolon. Then comes sustained release steroid implants. First will be Ozurdex with dosing of 0.7 mg which lasts around 3 to 6 months. Then comes fluocinolone acetinoid which has dosing of 0.18 mg. It lasts around 36 months. Indication will be chronic relapsing, non-infectious posterior uveitis, recurrent uveitic macular edema requiring more than 3 treatments per year. Monitoring can be done with measuring IOP at every visit. We can check for lens status for cataract progression. Macular thickness can be checked with OCT. Then we can also look for sign of infection. Fluocinolone acetinoid is available with the name of UT. Then contraindication will be glaucoma or steroid responders, acute or active ocular or periocular infection, uncontrolled controlled diabetes. Complication will be cataract, IOP rise, endophthalmitis, floaters, steroid induced glaucoma. Then comes the laser treatment, for which we mainly use organ green laser. with the wavelength of 488 to 514 nanometer, which comes under the blue-green spectrum. The principle is photocoagulation. Laser energy is absorbed, which is converted to heat, and it coagulates the leaky vessels or ablate the ischemic retina. The indication for PRP or panretinal photocoagulation will be proliferative diabetic retinopathy, ischemic retinal vein occlusion, neovascular glaucoma. For focal and grid laser, it will be extrafoveal diabetic macular edema, branch retinal vein occlusion, barrage and retinopathy for peripheral breaks or lattice degeneration. Laser for CSCR will be focal extrafoveal leak. Then comes the focal laser. Principle will be it seals the leaking microaneurysm and reduces the focal edema. Indication will be FFA confirmed leaking microaneurysm, diabetic macular edema not involving foveal center, vision affected but center is spared. In these conditions also we can use the focal laser. Then it is also used as an adjunct in persistent edema after anti-VEGF. Then the parameters for laser will be spot size around 50 to 100 micron, duration 0.05 to zero point 0.1 second. Power is to produce a light gray burn. Spacing should be directly over the microaneurysm. Then contraindication center involving diabetic macular edema, poor fixation, very close to foveal avascular zone. These are the contraindications. Then complication will be paracentral scotoma, enlargement of laser scar. Then comes the grid laser, which is modified grid or diffuse edema laser. The principle will be it reduces the oxygen demand and stabilizes the RPE pump, and then it reduces the edema. It also redistributes the retinal metabolism. Indication will be diffuse leakage without focal points, diabetic macular edema with center spared as a supplement in stabilized central involving diabetic macular edema. The parameter will be spot size 100 to 200 micron, duration 0.1 second, power light gray burn, spacing 1 burn apart, area temporal macula avoiding 500 micron from center. Contraindication will be center involving diabetic macular edema, active foveal leakage, poor media clarity. Complication will be decreased contrast sensitivity, paracentral scotoma, laser scar enlargement. Then comes the panretinal photocoagulation, also called PRP. The principle will be destroys the peripheral ischemic retina, which reduces the VEGF, which regresses the neovascularization and prevents the vitreous hemorrhage and transient retinal detachment. Indications will be neovascularization of disc, neovascularization of elsewhere, neovascularization of iris, high risk proliferative diabetic retinopathy, pre-vitrectomy for proliferative diabetic retinopathy, ischemic CRVO with high VEGF drive, severe non-proliferative diabetic retinopathy if poor follow-up or pregnancy is present. The parameters for laser will be for PRP laser, argon green, krypton red, or diode laser can be used, and wide field lens with the magnification of 2.0 used. Spot size will be 500 micron, separation half a spot size apart, duration 0.05 to zero point 0.2 seconds. Power for power we will start with 130 milliwatt, then titrate to achieve the mild white gray burn, and total burn will be used more than 1200 spots depending on ischemia or 1200 to 2000 typically. Laser wavelength option, as I already told you, organ green. It is most preferred than krypton red or diode. These are used better in media opacities. Then comes the location. Laser are used from arcades to equator. The nasal limit uh, will start and will spare 500 micron from the disc, and temporal limit will be 2.5 disc diameter from the fovea. General pattern which can be used is uniform spacing, avoid confluent burns near posterior pole. Then contraindications will be macular edema to treat first, then media opacity preventing retinal visualization, active ocular infection. Complication will be foveal burn, macular edema, exudative retinal detachment, increase in tractional detachment, optic disc damage, choroidal hemorrhage, choroidal neovascularization, choroidal detachment, vitreous hemorrhage, loss of visual field, loss of dark adaptation, corneal abrasion, lens opacities, mydriasis, paresis of accommodation, pain during treatment, increased intraocular pressure. Then comes photodynamic therapy. The principle will be vertiporfin drug is used with the 689 nanometer laser, which creates the reactive oxygen species, which selectively closes the abnormal choroidal vessels and reduces the choroidal hyperpermeability and subretinal fluid. Indication will be chronic or persistent CSAR, PCV best with anti-VEGF and resistant CNVM. The dosing will be full fluence or half fluence PDT. Full fluence will be 50 joule per centimeter square, and then half fluence will be 25 joule centimeter square. It is safer for CSCR and PCV. Laser exposure is done for 83 seconds, and laser is only given after the vertiporfin infusion, 15 minutes after the infusion. An infusion is used as a 6 mg per meter square over 10 minutes. Then 50 minutes later, we will expose the retina with laser for 83 seconds. The brand name which is available for vertiporfin is Visodyne for 15 mg. Monitoring can be done to locate the leakage in FFA, and for PCV, indocyanine green can be used, and we can follow for subretinal fluid by using OCT. The contraindication will be porphyria, pregnancy, hypersensitivity to vertiporfin. Complication will be RP atrophy, choroidal ischemia, photosensitivity, reactions, then CNVM scarring. The contraindication, the vitrectomy, pars plana vitrectomy is a surgical procedure used to remove the vitreous opacity, to relieve the vitreoretinal traction, restore the normal alignment between the retina and the RPE, to provide surgical access to the subretinal spaces. Indication will be non-clearing vitreous hemorrhage associated with proliferative diabetic retinopathy, retinal vein occlusion, traction retinal detachment, rhegmatogenous retinal detachment, macular hole, epiretinal membrane, endophthalmitis, intraocular foreign body. The trocar are used are 23 gauge, 25 gauge, and 27 gauge. And diameter for these trocar will be, for 23 gauge it will be 0.7 mm, and for 25 it will be 0.5 mm of sclerotomy, and for 27 it will be 0.4 mm sclerotomy. Along with vitrectomy, ILM peel or internal limiting membrane peeling can be performed if indicated, as in macular hole, ARM, or in selected cases of diabetic macular edema where traction is present. The dyes which can be used for ILM peeling is brilliant blue G, which is the safest, then trypan blue, then indocyanine green, which is the potent dye, but it has the risk of toxicity, so we need to use it at low concentration and for shorter exposure. Along with the vitrectomy, tamponade can be done with gas or silicone oil. SF6 or C3F8 gas can be used, and silicone oil is used for complex or recurrent detachments. Monitoring can done with OCT for ERM or macular hole. B scan can be done for vitreous hemorrhage, and IOP measurement can be done. Also, tamponade duration can be checked. Then comes the scleral buckling. Scleral buckling, it closes the retinal breaks by externally indenting the sclera, bringing it closer to the detached retina. Transscleral cryopexy can also be used along with the scleral buckling, as this cryopexy is applied at the retinal breaks to create a permanent adhesion between the retina and RPE. The goal is to achieve the retinal reattachment by both mechanical support or biological adhesion. In the pic, we can see there are so many types of buckling present, like various type of explant. These can be used like solid silicone tires of various size from A to C are trimmed at to the desired sizes, and D to F are silicone sponges. They may be used as well, and these are the circular one with oval cross sections, and G to I are the vasquez sleeves, and then the K. Ks are the silicone tires or bands. They are used to create the encirclement. The L1 is also used for the encirclement. There are three types of scleral buckling. One is the radial, and second is the segmental, and third is the encircling. Radial soft silicone sponges, these induce the little changes as we can see in the picture. The A1 is a radial scleral buckling, the B is the segmental scleral buckling, and then C and D are the encircling scleral buckling. The segmental scleral buckle, what it causes is the hyperopic shift, and then encircling, which is the C and D scleral buckles, they increases or decreases the axial length depending on the scleral buckle material, location of the buckle, height of the buckle, and also there are hard silicone encircling buckles available which increases the axial length. Occasionally high encircling silicone buckles are also available which decreases the axial length. The complication associated with pars plana vitrectomy will be postoperative nuclear sclerosis, long-term risk of open-angle glaucoma, intraoperative or postoperative retinal break, intraoperative or postoperative retinal detachment, intraoperative cataract, postoperative vitreous hemorrhage, postoperative massive fibrin exudation, postoperative anterior segment neovascularization, endophthalmitis, retinal phototoxicity, complication associated with silicone oil like glaucoma, band keratopathy, or corneal decompensation. The oral medications which are used as adjunct will be first the AREDS 2 formulation, which is the current recommended version. It reduces the oxidative photoreceptor damage. This formulation is available with the combination of nutrients like vitamin C, vitamin E, zinc oxide, copper or cupric oxide, lutein, zeaxanthin, vitamin C for 500 mg, vitamin C for 500 mg, which is used as an antioxidant. It protects the retinal cell. Vitamin E 400 international unit prevents the lipid peroxidation. Then zinc oxide 80 mg stabilizes the retinal cell membranes. Copper 2 mg, it prevents the anemia from zinc therapy. Then lutein 10 mg, it is a macular pigment. It filters the blue light. Then zeaxanthin 2 mg protects the foveal cones. Then Carbonic anhydrase inhibitor like acetazolamide, methazolamide. It mildly reduce the macular edema. It is available as Diamox. The mechanism will be it enhances the RP fluid pump, then improves the subretinal fluid absorption. It is used in refractive diabetic macular edema, cystoid macular edema secondary to BRVO, CRVO, Irwin Gast syndrome. Then comes fenofibrate, which slows the diabetic retinopathy progression, which is available with the dosing of 200 mg OD. It reduces the lipid toxicity. It reduces the inflammation by PPAR alpha activation pathway. It reduces the need for laser. It reduces the progression. It is best for patients with dyslipidemia and early diabetic retinopathy. Statins, it lowers the circulating lipids. It reduces the lipid leakage from retinal vessels and thereby decreasing hard exudates in diabetic retinopathy. Aplirenol, propranolol, rifampicin, these are used for CSCR. Aplirenol blocks the mineralocorticoid receptor and reduces the choroidal permeability, thus reduces the subretinal fluid. Propranolol, it reduces the sympathetic drive and cortisol activity, thus reduces the choroidal leakage. Rifampicin induces the cortical metabolism, induces its clearance, and reduces the mineralocortical receptor activation, reduces the hyperpermeability of the choroidals. These drugs can be monitored with serum potassium or RFT. The parameters or investigation can be done like for rifampicin, liver function test can be done for aplirenone, serum potassium, lipid profile or blood sugar or BP can also be done for these drugs. Contraindication for fenofibrate, renal failure, for aplirenone, hyperkalemia, for rifampicin, children or pregnancy. Then comes the non-manageable or retinal diseases with limited outcome. Retinitis pigmentosa, yet no cure available currently, but to halt the progression, vitamin A palmitate can be used of a dosing of 15,000 international unit per day. It slows the decline of ARG responses. It can only be used for ABC A for variant. Vitamin E less than 30 international unit per day can be used, avoiding more than 30 international unit. Then UV absorbing sunglasses and brimmed hat for photo protection can be used, and low vision aids can also be used. Associated entities like cystoid macular edema, cataract can be treated along with the retinitis pigmentosa. Nowadays, electronic chips or retinal prostheses are also available to connect the potent retinal tissue with the brain. Genetic testing or genetic therapy trials are also available. It is approved for liver congenital amaurosis, for RP65 gene. Geographic atrophy. No treatment reverses the vision, but it slows the progression. We can slow the progression with the ARIDS to antioxidant supplement by avoiding the smoking. Low vision can also aids can also be used. There is a newer drug available which is paclitaxel, which is a complement inhibitor, can be used intravitreally. It slows the geographic atrophy. It has the modest effect. Then comes the end stage macular scarring, CNVM scarring or toxoplasma scarring. Low vision aids can be used. Anti-VEGF can be used if only if activity recur at scar stage. No surgery can improve the central function when scarring is already present. Advanced optic atrophy, no reversal is available. We need to focus on preventing further vascular events. Low vision aids can be used. Neuroprotection trials are done but none proven. Chronic non-functional retinal detachment. Surgery is not beneficial if the retinal detachment is 6 to 12 months old and macula is atrophied, retinal thinning is present. Management is only observation and surgery only for cosmetic reason or to reduce the thysis bulbum. The supportive preventive management adds to or antioxidants. It reduces the oxidative photoreceptor damage, can be used for AMD or retinitis pigmentosa. Lifestyle changes like stop smoking, exercise can be done for AMD or diabetic retinopathy. It reduces the vascular or oxidative stress. Systemic control for diabetic retinopathy, retinal vascular occlusion, hypertensive retinopathy. It prevents the microvascular injuries. Low vision aids can be used for end stage AMD, diabetic retinopathy, retinitis pigmentosa. It maximizes the residual vision. Screening and follow-up for diabetic retinopathy, age-related macular degeneration or ROP. Detect the early treatable changes. Then comes the low vision aids. First, convex lens aids. These uses the convex lenses to enlarge the images for near tasks. First will be spectacle magnifier, which are available bifocally as well. Then spectacle mounted magnifier, dome magnifier, handheld magnifier, stand mounted magnifier. Then comes the telescope. It is used mainly for distant vision enhancement. First will be spectacle mounted telescope, handheld telescope. Then comes the non-optical devices, or these are also called adaptive aids. These do not use lenses but improves the visual performance through environmental or functional adaptation. First will be large print material, reading stands, marking devices, reading guides, writing guides, signature guides, pill organizer, liquid level indicator, large numeral devices, talking clocks, watches, timer, calculators, scales. Then comes tint and filters. These are used to enhance the contrast, to reduce the glare and improve the comfort. First will be tinted lenses, filters, anti-reflective lenses. Additional component with these are illumination. Proper lighting is considered an important part of this category. Then comes the electronic devices. It provides high level of magnification, offer integrate digital technology. First will be CCTV, closed circuit television, reading machine, which is available portable or desktop type. Then image scanner, electronic magnification system, then voice synthesis software, then voice recognition computer software. The take home message will be early diagnosis ensures the best outcome. Anti-VEGF has transformed the vascular retina care. Laser remains crucial for panretinal photocoagulation and selective macular diseases. Surgery restores the anatomy when medical therapy falls short. Individualized plans yield superior results. Thank you.